Hi, I'm Stephanie Hertz, Marketing Director at Workforce Retirement Community, the premier sponsor of CNU's Lifelong Learning Society. It's my pleasure to introduce today's speaker, Bianca Muntz. Bianca Muntz is the Director of Outpatient and Addiction Services at Riverside Behavioral Health Center. A native New Yorker, Bianca came to Hampton Roads as an undergraduate at Christopher Newport University. She has called Hampton Roads home for the last 15 years and received both her Master of Education in Addiction Counseling and Master of Business Administration from the College of William & Mary. Bianca is a licensed professional counselor, a certified substance abuse counselor, and an approved clinical supervisor in the state of Virginia. Bianca has provided behavioral health and addiction treatment to patients and their families in hospital, residential, and outpatient settings for the last 10 years. Since 2017, Bianca has focused on program development and utilizing visionary leadership to increase access to services for patients across the state. Bianca serves as a board member for the Virginia Association of Addiction Professionals and the Virginia Summer Institute of Addiction Studies. Today's lecture is titled, A Biopsychosocial Spiritual Disease. Please welcome Bianca Muntz.
And thank you for having me. I am so excited to be here to present. Thank you for those of you who came in person. Excited to see you. So I'm not in this building talking to myself. And thank you for everybody who joined online. I am really, really excited to be here. As she mentioned, I graduated from CNU, but I've never been in this beautiful facility before. So it's pretty exciting to be back. I'm looking forward today to talking to you about addiction. And I'm hoping to answer any questions and make this as interactive as it could possibly be, both in person and on Zoom. So please, if you're not here in person, put things in the chat, stop me, ask me to clarify things. I am a New Yorker. I'm going to try really hard not to talk too fast. So I'm Bianca. She already told you all these great things about me. I'm going to start off talking about addiction, and I'm going to end with talking about our services and hopefully provide some information for anybody who needs it. Okay, so today we're going to talk about addiction. Got to figure out where to stand. There we go. We're going to talk about addiction. As she mentioned, we're going to talk about the biopsychosocial and spiritual aspects of the disease as well as treatment. So it affects each of those components of a person's life and who a person is. We're also going to talk about how treatment can impact each of those components. We're going to talk a little bit about the impact on families. Addiction is often called a family disease and has impact on much more than just the person experiencing that illness. So we're going to talk a little bit about that and some resources that might be useful. And then we're going to talk at the end about the continuum of care. So I'm going to define all of the levels of care. We're going to go into what services might be appropriate for different people. So this is going to be the only math I'm going to do today, because although I have an MBA, I'm a therapist at heart and math is not my thing. But we do have a little bit of recovery math. So probably many of you have heard the saying, if nothing changes, nothing changes. That's a pretty common phrase, not just in treatment, but in general life. So what we're going to talk about today is recovery, the concept of recovery, what that means, what recovery from addiction means specifically. And that's going to equal abstinence, so the absence of using, no longer putting that substance in your body, plus change, but only where change is greater than abstinence. So recovery, as we're going to talk about today, is much more than just stopping using. All these other changes in behavior, in thoughts, in reactions, in communication, all these other things in addition to just no longer putting something inside your body. So that's our only math for today. Now we're done. So I'm going to start off by introducing, for those people who might not be familiar, the American Society of Addiction Medicine. So you can read up here a little bit about when ASAM was founded, what types of professionals ASAM represents, many professionals across the spectrum of treatment and across a multidisciplinary team of people. ASAM is what is now commonly accepted and used to define addiction, to define levels of care for addiction treatment, and also to define criteria for placement. So the ASAM criteria, which we'll talk about a little bit later, is what is commonly used by insurance companies, by hospitals, by treatment centers as the standard of practice for how do we know that this person needs this level of care versus they need this type of treatment. That's where we're going to start. I'm going to share with you the Acm definition of addiction. I'm going to try not to do too much reading off the PowerPoint, but this is one that I think is important to really go through and highlight some important pieces. So addiction is a primary chronic disease of brain reward, motivation, memory, and related circuitry. Dysfunction in these circuits leads to characteristic biological, psychological, social, and spiritual manifestations, and this is reflected in an individual pathologically pursuing reward and/or relief by substance use or other behavior. So just a couple of pieces that I think are important in there to break down. As you can see in the Acm definition, addiction is a primary disease. So what that means is there does not have to be something that has caused addiction. Addiction can exist on its own without being a secondary to another type of trauma or illness. There is all of the components that we talked about in the title of the presentation today. So there are changes that happen biologically within your brain. There are changes that happen psychologically within action, communication, emotional impacts, social impacts. I think those are the most likely to be obvious among people who have family members that have suffered from addiction or people who've known someone, as well as spiritual manifestation. This is one that is important to include and sometimes gets kind of tacked on at the end there, but definitely important to focus on. And then this last piece that's bolded here really defines what I think people see addiction. Addiction is pathologically pursuing that use over and over again. So this is where we see people who are drinking on the morning of their court date, even though they know they shouldn't be doing that. These are people who are using substances instead of spending money on their rent or something like that. So pathological pursuit of that use, but the use is either providing a reward inside someone's brain or providing relief from some of these other symptoms we're going to talk about. So to just carry that through a little bit more, this is the long definition of addiction. So if you went to the Acm website, you'd see their short definition, which is that first slide, and then you'd see this as their long definition. So it describes some of the characteristics such as inability to consistently abstain. So these are people who say, I can quit, I just can't stay quit. These are impairment in behavioral control. These are things that are obvious, things like that. Cravings, which we're going to talk a little bit more about because a craving in the context of addiction is not the same as it's Easter time and I see all the Reese's cups at Walmart and I would like to eat all of those things, even though I shouldn't. So we're going to sort of clarify the difference in what craving looks like in this context. And then diminished recognition of significant problems in behavior and interpersonal relationships. So this is the denial aspects of treatment. This is where people seem to be unaware or maybe refusing to see some of the problems that are being caused. Something that's important to note, similar to many other diseases, addiction is often characterized by having cycles, so relapse, recovery, relapse, recovery. This illness can be fatal if not treated properly. If treated properly, can have as good success rates as other chronic illnesses that involve similar cycles of relapse. So I think that's really important to highlight. It is a progressive brain illness. All right, so I'm going to use the phrase addiction a lot. I'm going to use that term a lot. You also may hear professionals use substance use disorder. Both can be used interchangeably, but I did want to highlight what we're talking about when you're talking about substance use disorder. So the DSM-5, which is the big purple book of all of the things that could be wrong in your brain, all of the illnesses you could be diagnosed with in terms of brain disease or mental illness, including addiction. That's the big book that psychiatrists use. They've established 9 types of substance disorders. So for the purpose of having a diagnosis and that diagnosis being reported to your insurance company so that you can be, your bills can be covered for when you seek treatment, they've clarified into 9 sections. So alcohol use disorder, cannabis use disorder, and on and on and on. The treatment, in my experience, is not significantly different from a therapy standpoint for one type of substance than for another, but there are reasons to clarify which substance. As you can imagine, there are different detoxes associated with each of these substances, and there are different medical treatments, so potentially different prescriptions that might be given or different alternatives based on substance. So from a therapy standpoint, not always important to clarify what the substance is, but from the medical side of things, it would certainly be important and necessary. So for substance use disorder, regardless of the substance, we're going to look at 4 categories of how there's been impairment in your life because of the use. So regardless of what substance you're using, what is the impact it's having on these 4 areas of your life? And this is how somebody would do an assessment and make a diagnosis. So impaired control, social impairment, risky use, and then pharmacological indicators. So we're going to talk a little bit about tolerance and withdrawal, what that means. So for the first category, which is impaired control, we're talking about use that is no longer social, is no longer able to be managed effectively. And so that could look like, I intend to go out and use for an hour, go have a drink and come back home, but somehow lost track of time and now it's 5 in the morning. Now it's the next day. So using for longer periods of time than intended, or using in amounts that are greater than intended. So again, that same example, I intended to go have 1 or 2 drinks with some colleagues after work, and that spiraled into drinking 10 drinks, and I didn't have set up a way to get home. I didn't have a safe plan for that. So use that is not what I planned to have happen. The second characteristic of that would be wanting to cut down and not being able to do so, or not being able to do so consistently. So if I am consistently making a plan with myself that I'm only going to have those 2 drinks, and then every Saturday gets out of control, or the one Friday I can do it and Saturday I can't do it, we're looking at some inability to control there. The third is that excessive time, and that includes getting, using, and then recovering from substance. So these are good examples of that. These are people who are calling in late to work the next day because they are still recovering. These are people who are missing an important event because they ran out of time. They didn't plan for their time appropriately. And then the fourth is cravings. So cravings that are so intense, it's difficult to think about anything else. It's difficult to redirect that thought. It's difficult to move on from that thought. There is a singular focus on it. So this, again, as I mentioned earlier, this is different than I'm craving some chocolate and then I go upstairs and go to bed, or I turn on the TV, or I eat an apple and something else happens. These are intense physical cravings that often have different associations. So my patients will describe things like having knots in their stomach that don't go away until they'll describe things like their shoulders being so tight until they are able to satisfy that craving. Second piece we're going to talk about is social impairment. So for the purpose of this, we're going to include this additional definition. So we're just adding a little bit more clarification on how this might socially impact. So repeated involvement in a substance, despite the harm that it causes or potential harm that it caused, because that involvement was or continues to be, so that's an important distinction, it no longer has to continue to be pleasurable or valuable. And this is one example of a consequence that happened. So people continuing to use despite having problems in one important area of your life. So that area of your life could be your work, that could be your friendships, that could be your marriage, that could be your parenting, other people in your family, but continued use despite knowing that this use is causing a consequence in those important and valuable relationships. And depending on the severity of illness, can be anything from arguing with family members all the way to the spectrum of neglecting children, losing custody of children, things like that, failure to meet responsibilities. So we're also looking at continued use despite having interpersonal problems. So these things kind of go together. So one is talking about those interpersonal relationships. The second is talking about responsibilities that you might have in those relationships. So these things go together pretty well. And then the last thing is probably one of the most common symptoms of addiction that I see in practice, and that's the social and recreational activities that are given up or reduced. So this often happens over time, and for me, it's one of the telltale signs that somebody's use has progressed or their illness has progressed significantly, is that they can recall a time where they enjoyed other activities, yoga, bowling, whatever that might look like. And over time, if those activities did not involve their substance use or was not associated with their substance use, those activities tend to fall off. So if you think about your priority list, and it's important for me today to go to work and then pick up my kids from school, and then we're going to go out to dinner. These are some things I have to have on my list. As addiction becomes progressively worse, the priority of those things falls further and further down. You can imagine that things like recreation, activities we used to enjoy, fall further and further down as addiction creeps higher and higher up. Again, most often what I see with this is activities that are not associated with using. So if the patients are not if my patients are not finding a way to continue to use it during these activities, they're falling off the list. And it's one of the really exciting aspects of treatment because there's this free time now. We talked earlier about one of those criteria being an excessive amount of time is spent using, recovering from, obtaining, leaves a lot of free time once somebody gets into recovery. So a really exciting part of treatment is, let's think about what did you used to enjoy you're not doing anymore? How can we integrate that back into your treatment? How can we integrate that back into your life? And if you can't think of something, what are some new things that might be worth trying? So this is a little bit of a side note, but it's what our recreation therapist is so great at in treatment, because she will come up with all of these activities that are in Newport News and Hampton that our patients can access for most of the times no money at all, but sometimes maybe some money. But she helps them identify what are some recreation activities that you can spend your weekends doing now that you have free weekends, now that you're physically feeling better and starting to recover. So it's one of her really good talents. The third category in terms of criteria that somebody's looking at in terms of a diagnosis would be risky use. So repeatedly using in dangerous situations. The very obvious example of this is when driving a car, but there are some other examples of this as well. Using any sort of equipment, doing anything, working in a place while actively under the influence that might be dangerous, a factory, shipyard, something like that. And then the second thing that falls under risky use is continuing to use even though it is known that this is causing or worsening other illnesses. So if you have addiction and you also have high blood pressure, those things don't tend to go well. If your doctor has informed you that your liver tests are elevated and you continue to use alcohol, those things don't line up. So continued use despite knowing that it's causing some additional problems. Alcohol in the liver is a great example of that. The example they give here that makes perfect sense is people who continue to use tobacco or continue to smoke, knowing that they have COPD or knowing that they have lung cancer. That's what addiction looks like. And then the last category we're going to talk about is tolerance or withdrawal. I think these are pretty well understood things, but just to define them pretty briefly, tolerance is, we're going to look at tolerance two ways because both things happen in the context of addiction. So the way that people are most familiar with is that it takes more to achieve the same effect. So if when I was 19, I had one beer, I felt tipsy. By the time I was 25, it took me 3 or 4 to have that same impact. That's what tolerance looks like. And most people will experience that regardless of having addiction or not, regardless of having this illness. People who are on medications for periods of time might experience that they need to change their dose because their body has built a tolerance to it. So that's a normal biological thing to happen. The opposite side of tolerance happens frequently when patients have used enough substances or caused enough damage in their body physically that reverse tolerance will happen. So that is where you used to be able to, quote unquote, hold your liquor, but now you notice that you can't anymore. One really obvious example of this is patients who had gastric bypass surgeries. What I've seen in patients in my practice before has been patients who have those surgeries can no longer drink alcohol the same way that they did previously because of that reduced tolerance. And then withdrawal is the one that's going to look significantly different depending on what substance you've been consuming, depending on the amount and the frequency of consumption. So there's not many other places in the diagnosis where we're looking at the amount and frequency of your use, except for when it comes to withdrawal. So one thing that I always share anytime I'm talking to family members, patients, anyone that might need this information, is that withdrawal from alcohol can be physically dangerous and can be life-threatening. It is not something that's recommended to do at home. It is something that's recommended to do under the supervision of a provider. So if you've been drinking all day, every day for an extended period of time, you don't want to do that at home. You want to seek medical guidance, and you do want to get some support around that. The reason for that is because alcohol withdrawal can potentially cause seizures or potentially change your blood pressure enough to cause a stroke. So you just want to make sure that you're safe around that. The other medication that has a similar effect in your body to alcohol, so should also be monitored by a provider, is benzodiazepines. So these are typically like anxiety medications. There are some of them that you can develop a tolerance for and also can have similar withdrawal impacts. Benzos and alcohol in the hospital are looked at pretty similarly in terms of how we help patients taper down safely and securely. Other substances are going to have sort of characteristic withdrawal. So opioids, for example, are going to have flu-like symptoms during withdrawal, oftentimes very, very uncomfortable and painful. Those are ones that most people are going to want to see a provider and get some support around because it's very unpleasant. And then anybody who stopped using caffeine or stopped using nicotine knows how quickly that withdrawal can set in and how uncomfortable that can be. So caffeine, it's likely that you're going to get something like a headache and maybe some nausea. If you stopped using nicotine, you know what those cravings feel like and those similar withdrawal symptoms. So when you look at, before we move forward, when you look at all 4 of these categories, somebody is coming in for treatment, they're going to get assessment, they're going to talk about a lot of history, they're going to talk about all of these categories, and then depending on the number of these symptoms that somebody has experienced in the last year and the severity of the impact that those symptoms have had on their areas of life, their areas of functioning, is going to depend on how we label that use disorder. So if it's alcohol use disorder, it could be mild, it could be moderate, it could be severe. And that is going to lead a little bit into how we make some determinations around treatment. So that's just one thing to be aware of. These symptoms have to be experienced in the last year, and they have to be having an impact or an impairment on functioning in any of these areas of life. Okay. So we're going to talk a little bit more now that we've defined addiction, we've given some criteria around what that might look like, how somebody might identify that. We're going to talk a little bit about how this happens. Everybody heard my bio, so you know that I'm not a doctor, not pretending to be a doctor, but we're going to talk a little bit about the brain. I've had the benefit of working with some really, really smart people and being able to learn some things. So not everyone who engages in a pleasurable behavior is going to end up being, not everyone who drinks or uses is going to end up an alcoholic or an addict. We know that. So behaviors that can become addictive are either encouraged or discouraged by larger social forces. So the example I like to give for this is anybody who's ever seen a commercial that advertises alcohol on TV knows at the end of the commercial they say what? What are the two words that's at the end of any commercial ever? Drink responsibly. Yes, those are the two words at the end of all the commercials in the history of ever. And there is a context for what that means. So when they say drink responsibly, what are they really saying? What's the message that's received? Don't drink and drive. When you hear drink responsibly, most people hear that message and hear don't drink and drive. Now, maybe that's not what you think. Maybe there's other things you think of when you think drink responsibly. But I would say a good amount of people think don't drink and drive. And then what that means is I can do any other thing as long as I don't drink and drive. Now, most people are not going to take that message away from it, but it's just something important to consider. What are our kind of societal beliefs on that? Is being drunk okay as long as you don't get in a car? Are there levels to that? Probably. And then there's factors besides external factors, but there's internal factors that impact addiction. And we're going to talk more about genetics and biology a little bit later. I'm not going to go very far into that because, again, I'm not a doctor. But if we understand that there are certain behaviors that create reward or relief for people, so we talked about things that either were pleasurable, continue to be pleasurable, or were pleasurable and now provide relief, they now provide escape, then we can understand a little bit more about how addiction happens, how it continues. All right, so this is the title of our presentation. This is the factors we're going to review. So we already talked about in the definition that we're looking at biological, psychological, social, and spiritual. And I'm going to address kind of in three parts, the factors that contribute, the results of that on that particular area, and then what treatment potentially looks like. There are lots of different treatments out there. We'll talk a little bit about some options that I've participated in and what we've seen other people do. But there are lots and lots of really unique and exciting treatments that are out there. So I said that we were going to talk a little bit about genetics. So there is evidence that supports that people inherit a higher risk of dependent behavior than others. Any assessment you have related to addiction is going to ask about your family history. Similar to any other time when you go into a provider's office and they ask you about your family history of cancer, they ask you about your family history of diabetes, whatever that might look like. This type of assessment is going to ask about family history of mental illness, including addiction. And there's evidence to support that. So the highest risk for that would be to have a sibling or a parent with a history of dependence. So those are biological factors that contribute. And then in terms of biological results of addiction, I think these are pretty commonly well known. So depending on what type of substance you use, will have different biological results or physical impacts. So heart, liver, stomach diseases, I think it's pretty well known. Drinking could cause cirrhosis, tobacco use could cause cancers, that sort of thing. Skin, teeth, and vision issues are often associated with other substances that are used and actual changes in your brain and how your brain functions. So I'm going to tell you the way that somebody who's much smarter than me explained it to me, understanding that I'm not a doctor. So your brain has certain pathways, that's how it works, and it can learn things. So if you've ever been on a sidewalk and there's a turn, a 90-degree turn in the sidewalk, and you know you're supposed to walk to the sidewalk and then follow it down the path, but you see that path that goes straight across here, and it's like run out in the grass, and you can see the dirt. So when that happens, it's because people are cutting that corner. They're not going all the way to the end and then turning left. They're cutting a diagonal across and it's worn out the grass. Somebody comes along and they put a sign up that says, "Don't walk on the grass." Looks not fair. you're ruining the grass. If everybody follows that sign and they don't walk on the grass for long enough, the grass will eventually grow back. It gets better. What's been explained to me is that some loose degree, that's how our brain works too. We can, with addiction, create new shortcuts that shouldn't be there with use, continued use, create new pathways that shouldn't be there. And if we don't use them, if we retrain our brain to go all the way to that corner and turn that 90-degree turn and keep going the right way, if we retrain our brains, we can go back to those pathways that we should be using. That is my very non-scientific explanation of that. So to talk a little bit about the psychological factors that can contribute to addiction, as well as the impacts of addiction. Things like anxiety, depression, certain personality traits like perfectionism, personality disorders, traumatic experiences, as well as eating disorders, all have high correlations with addiction. In fact, there's a good amount of eating disorder treatment that also includes addiction treatment because of how high that correlation is. Similar to, you may have heard of co-occurring treatment facilities that treat both mental health and addiction together. At this point in the progression of our field, I think it would be unrealistic to think that you could treat one without the other. We really need to be able to holistically treat our patients. And then the results of addiction that are psychological, so irrational or inappropriate arguments. If you've ever argued with somebody in active addiction, we could both be looking at this chair that's clearly green and you're telling me it's yellow. Pre-existing conditions can get worse. So if you have a pre-existing depression and you are actively using alcohol, which is a depressant, your depression is likely to get worse. Any treatment you're doing for your depression when you're actively using is unlikely to be successful. Similar to if you have anxiety and also are using a stimulant, for example. A stimulant and anxiety don't tend to go that well together. So treatment for those are not going to go very well. Examples are up there about denial. We talked a little bit about denial earlier when we talked about those relationships and the impact it can have. So being in denial about how you're impacting others, what harm you're causing, that. And then parts of self being disconnected. We talked about interest shrinking. So now we're talking about social, again, the factors that contribute and then the results. So for social, there can be social anxiety that contributes, relationship problems, loneliness, advertising, culture that contributes. I worked for a brief period of time at William and Mary's Counseling Center when I was in school there. And it was very common that we were talking about societal norms or cultural norms around using in college, what that looks like. So that was a pretty interesting to be a part of and to learn more about. I have an activity that I do with patients where we look at sort of a decision matrix and we look at what they might have to give up if they gave up their use, if they gave up their drug of choice. And one example that comes to mind that relates to this is someone who told me that he could only be confident enough to dance if he was under the influence. He was not going to have that confidence to dance if he was under the influence. And so we had a conversation about that, about if that's something that's worth giving up, if that's something that we could, a goal that we could work toward. Ultimately, he did decide that even if he couldn't get up that confidence, it was probably worth it. And that might seem like a small example, but it's important to explore those things that might be barriers to participating in treatment. And then results of addiction, isolation is a huge result of addiction. It impacts families, it impacts relationships. And so people become more and more isolated and less likely to ask for help, and less likely to have that social connection where they know who they could reach out to ask for help. Spiritual. So this is the part that I mentioned earlier, often gets left off or often doesn't really get discussed as much. So feelings of emptiness, meaninglessness, hopelessness, not feeling a purpose, feeling punished or forgotten. Those are all things that could contribute, but there are also things that could be results of. So that inability to experience a connection broader than self is something that is very, very common in addiction and very much needs to be addressed in treatment. And I think there's been progress just in the decade or so that I've been working in the field recently. I think there's been progress in including what spirituality means and defining that in terms of the differences between spirituality and religion, and that one doesn't necessarily equal the other. So I'm going to go back through these now and talk a little bit about treatments for each. Each treatment is going to be really individualized and it's really going to vary. So I'm going to introduce a couple of things, but it's certainly not an all-inclusive list of everything we might do to treat someone. So biologically, treatment is going to start for people who need it with that detox. So it's going to be with safely getting everything that's in your body out of your body and then sort of resetting you from there. So for some people, that's going to take a period of time. I'm going to give some general numbers. So withdrawal from alcohol might look like somewhere between 3 days and 10 days, depending on a person's biology. Withdrawal from opioids is going to be a little bit shorter. So each thing is going to have its own period. Withdrawal from nicotine is very, very quick. The unfortunate thing about smoking is that it gets really to your brain very quickly. So you're in withdrawal almost as soon as you are done smoking, wanting to have another cigarette. So treatment is going to look like first getting those things out of your body. And then second, for some people, medications to support that. So there are medications to support reducing craving. There are medications to support reducing the intensity of craving. There are medications to support any other illness that you might be have associated with your addiction. You might need some blood pressure medication. You might need something for anxiety. That's what that's going to look like. Psychological treatment is going to fall into a few categories. So one is going to be therapy. One is going to get to spend some time in a room with me or somebody else like me. We're going to talk through some things. In addiction treatment, what is most commonly accepted as the most successful form of treatment is group therapy. So patients do well in a group of people who understand what they have been going through similar things, where they have a facilitator to support that environment. So, I think people are pretty familiar with 12-step, AA and NA in the community. There's other types of 12-step meetings that happen. That's not treatment, but is a support to treatment. Those are community peer-led support. So when we're talking about group therapy, there would be a facilitator, a counselor, a peer recovery specialist. There would be somebody providing that. Could also include things like individual therapy, marriage counseling, family counseling, anything that you again, this is where once that withdrawal has been complete, once somebody is working on recovery, we might look at, is there a co-occurring depression? Is there something else that needs to be looked at with anxiety? And then social. So this is where treatment is really, really fun. Again, our treatment is oftentimes in groups. It's where addiction therapy thrives. And so things like referring to those 12-step meetings, celebrate recovery meeting for who is spiritual or religious, that recreation therapy, that art therapy, all those really good little things to put into a treatment. Art's so successful. And then spiritual. So I mentioned celebrate recovery, which is a commonly used one here. In other parts of the country, there are some other spiritual treatments or spiritual social peer groups that happen. I can't think of the name of the one that's really popular in Texas, one that's making its way up from the South, increasing. We have a chaplain that joins our group once a week and talks about kind of that purpose, that feeling of connection to anything that's bigger than yourself. So that might be to your family, that might be to the group that you're in, might be to the universe, whatever that looks like for you. Okay, so similar to this, we're going to we've described a little bit about what treatment looks like and some factors, but this list just describes some of those disease symptoms that you might see, you might be familiar with, kind of pulls everything all together. So preoccupation, cravings, tolerance, denial, all those things that are obvious symptoms of the disease, some behaviors that are common with the disease, rationalizing, justifying, making excuses, talking about why this makes sense. If you had my wife, if you had my dog, if you had my job, you'd be drinking too, that kind of thing. And then feelings that are experienced in active addiction, things that are frozen, things that are not able to be expressed, and all the other psychological and social factors that impact not being able to share feelings. All right, so this is one of the educational tools that I use in treatment to describe for patients, but also for their families. So you could look this up online. I didn't create it. It's something you could find there. And it just talks about some of the phases of addiction and what treatment can look like. So if we have the progressive phase, this is where use is turning from being social, appropriate, fun, manageable, to being used for relief, to being used as an escape, to being used for a purpose other than, general enjoyment. This is where tolerance is starting to develop, and some people might be noticing that something is changing. The next is that crucial phase. So you're going to see an increase in use. You're going to continue to see increase in tolerance. And as well, you're going to see more problems. So I mentioned in that first phase, people might be noticing here, we're going to be experiencing some consequences, starting to experience some consequences. And then chronic phase. So at this point, things have become unmanageable. They're no longer in control. There are consequences that are happening. And some people will stay in this phase for extended periods of time. Not everyone is able to access treatment. Not everyone is in a place where they can reasonably access for lots of reasons. So people might stay in this chronic phase. And then this green where things start coming up is this rehabilitation phase. And I'm going to come back to this when we talk about family systems, because as I mentioned, families are impacted by addiction similar to the way parallel sometimes to the way patients are impacted. And so we're going to talk about what this rehabilitation phase looks like for families and if that curve matches and is parallel on the way up. So this might be somebody gets treated, somebody stops using, somebody starts going to eating, somebody goes to detox at the hospital, whatever that looks like. This is an active working phase, so there are still consequences being experienced. There's still stuff that needs to be worked on here, but we're sort of trending up. And then we have this recovery phase. So things are better. We have a plan, we have a system that's working. We're attending meetings, we're attending groups, we're taking care of ourselves. We've got coping skills to deal with anything that might arise. And so some people will stay in this recovery phase, and that will be the rest of time. As we mentioned, relapse does happen, and there can be cycles of this curve that people can come out of. So to move from that a little bit into switching gears, talking about the impact of family. I'm going to pause for a second, see if there's been any questions before we move into family. Okay, good. All right, so I'm paying attention to the time as well, so I don't talk for too long. So for family systems, we're going to describe sort of what a healthy family system looks like. We're going to describe what I'm going to call an addicted family system. That's a family system with somebody with addiction in it. And we're going to talk about the parallels in both addiction families and then recovery families. So in family systems, we have good self-worth. We have the ability to communicate. So I can come to you and tell you that I'm concerned about you. I can talk to you about a problem that I'm having. I can do that directly. I don't have to go to you to tell you, because if I tell you, you're going to be upset. We don't have to have triangles. We can have clear communication. There's rules in healthy family systems. There's expectations, but those things are flexible and they can change as the situation. So as you get older, you have more freedom. Teenagers can start to drive. They can spend time on their own, things like that. So there's rules, but they're flexible. As well as the roles are flexible. People can move around in healthy family systems. There's links outside the family. So in a healthy family system, it's appropriate to also have friends. It's appropriate to have coworkers. It's appropriate to be involved maybe in a church or a club. And people have goals and plans. Those things are. In an addicted family system, some of these things look different. And sometimes they look different predating addiction. And sometimes they look different as the family adapts to having addiction. So I think I'm going to have, all right, that'll be next. So what happens in a family system with addiction is things tend to organize themselves around the disease. So because this disease becomes so big, as it progresses, it takes up more and more space, and more things need to happen to accommodate it. And so that happens, things change, the rules change, the roles people play change. Things start to readjust around addiction. And people are doing the best they can to try to keep things consistent, to try to keep things stable, to try to keep things on task, all of which are things that addiction throws off. Addiction and consistency don't tend to go together. Addiction and stability don't tend to go together. So there's this constant feeling of trying to readjust. And this picture is the perfect example of that. So this is one of those mobiles. You see them over like a nursery, a crib or something like that. And as everyone knows, if you hit one of those things, the whole thing would move, not just the one string. Everything sort of rocks back and forth. So something happens inside a family system, something gets knocked out of place, the whole system moves around to readjust. Eventually, it'll find its balance again because it's balanced to be in a specific way. When addiction comes into a family, and let's say it makes one of these blue stars weigh 50 times more than what it weighs, the system can't readjust. Everything goes a little bit sideways. And that becomes sort of a new norm. And so things get readjusted for that. And there needs to be a change in that. And that's what that treatment looks like. So we're going to talk a little bit about parallel traits. It's important to know that these are like natural responses. They are sort of like crisis or trauma responses. So it's not an accusation that anybody's doing something wrong. These are just things that tend to happen in family systems that have addiction. So if you look at the person with the illness, there's preoccupation that's experienced. So they are worried about, am I going to get enough? Do I have enough? Am I going to keep enough? Using enough? That sort of thing. Oftentimes that comes with behaviors like hiding, lying, sneaking, things like that. There is a tolerance. That tolerance is for the substance. We've already talked about what tolerance is. That's something that happens biologically. And then there's efforts to control. So as things start to get a little bit more out of control, I try to rein it back in. And generally those efforts are unsuccessful as the disease progresses. In family systems, there are some similar traits that happen. So there's preoccupation with the person with the illness. That makes complete sense. If I know that there's something going wrong here, I'm going to be preoccupied with what can I do to fix it? How can I change this? What are the problems? There's going to be tolerance. So oftentimes what happens is we make a little accommodation, break a rule, or we push the line in the sand out a little bit further, and those accommodations are similar to tolerance. And then there's efforts to control. And I have seen those efforts to control ranging everywhere from searching people's belongings to setting an alarm at certain times throughout the night to check on someone to make sure that they're there. Some more parallels related to feelings. These are some emotional parallels. So there's denial or minimization. It's not that bad. I still got this. I still can handle this. And again, those same kind of thoughts and feelings are being experienced by family. I can handle this. It's not that bad. We can deal with this within ourselves. We don't need to ask for help. There's protection. So sometimes this will look like if my spouse is in active addiction and they can't show up to work the next morning, I might call their boss and make an excuse. I might say he's sick. I might say the car isn't working. I might do something to protect them from not having a consequence. And that makes sense, right? I can justify that with I need the paycheck. We need the insurance, we need all these things. So there's this attempt to protect from consequences, not just the person with the illness, but the family as a whole. And that's similar to protecting the substance, protecting him. And then there's some lifestyle accommodation. So I might, as a family member, accommodate my schedule because I feel like I need to keep track of what this person is doing. I might not have as many social activities because I'm embarrassed that my spouse might overuse at a social function or the work Christmas party. And so maybe I decide we're not going to go that year. I might get embarrassed about what happens. You can see that there's some parallels happening. So this is a drawing. I'm not a math person. I'm not an artist. I'm just a therapist. So we're going to look at this drawing. So if you remember that curve earlier, where things start to get worse and worse with active addiction, they're kind of spiraling down, and then they might go up. And it's not going to be a perfectly going back up, bounce back straight line. There's going to be bumps in the road. There's going to be some consequences, but we can expect that if people are doing the treatment, that they tend to get better at a reasonable rate. What happens with family members is something interesting, because many treatments are designed to treat the person with the illness, and there might be some inclusion of a family member. There might be some participation, but the treatment is designed at this person with the illness, even though it's likely that the family members have been experiencing many, many similar symptoms. And so what that means for family members is that their line doesn't shoot back up quite as quickly. Generally, they experience, so in the example, I worked in residential treatment for a lot of years. And so that's that, standard 30 days that you think of. They go over here, they're going to get better. I'm going to stay here at home. And so family members in those situations oftentimes initially feel some relief. They have a break, there's a burden that's taken off of them, but they are not getting that 6 hours a day, 7 days a week that somebody with the illness is getting. Usually, they might not be, or sometimes they might not be getting anything at all. Sometimes family members are seeking help for themselves too. Maybe they're going to individual counseling. Maybe they found an Al-Anon or a Nar-Anon group that they can be by in the community. But sometimes they're just at home to pick up the pieces and keep things moving. So their line, it doesn't tend to bounce back up as quickly. And I think that's something to look at in terms of like a gap in services or ways that treatment can be adjusted. So what we're going to talk a little bit here is codependency. Again, not as an accusation of anyone, but something to think about in terms of what living with addiction might do to a spouse, to a family member, what the impact of that might have, and where you might be able to get some support if that's something you've experienced. So this is one definition of codependency. So it says when a person in addiction is not required to face the consequences of their actions or fix the problems themselves, then they don't have to change. If they know someone is going to jump right in and solve those problems for them, they have the ability to continue making some unsafe or unhealthy decisions over and over again, maybe without experiencing loss. So in that example I gave earlier, when I call in every Tuesday when my husband's hungover, I'm preventing him from experiencing a consequence. And I might have a really good justification for that, but the outcome is he's not in a place in regards to that consequence where I am forcing a change. So this relationship is sometimes called enabling. You're going to hear that word in addiction frequently, or could lead to codependency. So codependency means that the way I'm feeling about myself is dependent on how someone else is doing. So I am changing sometimes what I value, my thoughts, my actions, my feelings based on what somebody else is experiencing. And I have an illusion of being able to control someone else's thoughts, behaviors, actions. And that pattern can be painful and oftentimes results from living in a situation or being in an intense relationship with someone who has this addiction or compulsive behavior. I'm going to switch gears a little bit away from family systems, unless anybody has any questions. Excellent. That is such an excellent question. So I'm going to repeat the question and make sure that I've got it right, and so everyone can hear it. So the question is, are there statistical differences between someone who voluntarily chooses to participate in treatment, such as detox, or someone who is forced to be there, I assume maybe by a family member, the court system, what have you? It's a really, really interesting question, and I'd love to do some research to be able to tell you a number. Can't tell you a number off the top of my head, but I will share a little bit about what my experience has been with this, because it's a really common question. You've heard the phrase that you can lead a horse to water, but you can't make him drink. You can put someone in a safe situation. So ultimately, there are few situations in which we can legally compel someone to participate in treatment. In Virginia, that is a TDO, and you have to be representing an immediate threat to yourself or someone else. So generally, detox is not going to fall into that. But there's lots of ways to force somebody into treatment that isn't legal. So that might look like go to jail for your DUI, or you can go to treatment, or we're going to get a divorce. You can go to treatment, or you can move out of this house. So there are ways to force things without it being legal necessarily. And a good amount of patients I've worked with over the last decade have been patients that are forced there by some external consequence. It's not my experience that most people are waking up on a Tuesday morning saying, you know what, enough is enough. Today's going to be the day I go there. They're going there because the consequences have outweighed their experience at that point. So most people are coming into that situation. And oftentimes people can find internal motivation, even if external motivation is what brought them in. And sometimes it just takes being in a safe environment, having the substances out of your system, having some support to be able to identify some of that internal motivation. But that would be some of the work that we would be doing in terms of counseling. We would be looking for, what is your motivation to be here? Yes, your wife wants you to get clean. Yes, the law wants you to get clean. Yes, it's better to be in jail because the food's probably better. But what are some internal reasons that getting better is going to be successful? In my experience, people who are able to identify those internal reasons that getting better is important to them, that recovery is necessary for them, those people are able to experience lasting change and lasting recovery, regardless of what the situation brought them in. Excellent question. So the next question was, what treatment resources are there for those people who don't have health insurance, which is such an important question because not everyone has access to health insurance, and treatment can be expensive. There are some financial barriers to that. There also might be barriers in terms of needing housing, needing other kinds of support. So we treat at Riverside Behavioral Health, we treat a good amount of patients who don't have insurance. And also a significant portion of our patient population are homeless. So our team is constantly looking for sober living environments, halfway houses, shelters, places where people can be. And there are some places that are local as well as across Virginia that you can access for treatment without health insurance. So I'm going to give a few names. I'm not specifically recommending one or the other, but just to give at least where to start looking. But you can also call our admissions and we can help you with resources as well. But locally here in Newport News, Faith Recovery doesn't require health insurance. A little bit further out in Winchester, Edge Hill, the residential treatment center. And then where I work at Riverside Behavioral Health Center is not required to offer levels of care I'll talk about. Other questions? All right, we're going to keep going. Ooh, gotta look at the time. Okay, so the last piece we're going to talk about is the levels of care. So this is really like getting clarity on what treatment looks like. There's lots of treatment options out there, what that could be. So again, we're going to refer back to ASAM. That is what's commonly used to define a level of care and what's appropriate for levels of care. So we've got inpatient treatment that could include detox or residential treatment. Again, that standard like 30 days that people think about if you've seen movie, 28 days, that kind of thing. Also could include detoxing in a hospital. Things that are included in inpatient, we're going to go over. Step down from that is our partial hospitalization program. That is day treatment, so it does not include housing, but does include an expansive amount of services. Step down from that is IOP. That's the ACM 2.1 level of care. It's a little bit less services than PHP. And then step down to that is outpatient. We're going to review what's in each one of these things. But what I want you to notice about this is it's a stair-step approach. So the idea is not you go into detox for 3, 5, 7 days and then come out and jump down to outpatient. You think of this like stairs. If you fell down the stairs, that's going to hurt. So the idea is not that you jump. The idea is an integration back into the community. And you could enter this. It's not that everyone has to go from 3 all the way down. You can enter this at any point, depending on what you're currently experiencing and what level is needed to address your symptoms. So in inpatient treatment, you are talking about limited outside engagement. You're in a hospital, you're in a treatment center where you're staying. Depending on where you go to treatment, there's going to be different rules around that. Some places allow coming and going from the campus. Some places it's going to be an enclosed environment. You're going to have around-the-clock care. This could include nursing staff, medical staff, pharmacy, dietitian, therapy, all these resources in-house. You're looking at multidisciplinary treatment teams. This is where your withdrawal management would happen. So it's a very significant level of care, but generally pretty short in the context of your whole scale of treatment. The next step down from that, go ahead. Absolutely are. So the question is, in partial hospitalization, exercise and diet are listed, and they're not listed in the other levels of care. Absolutely would be important in all of the levels of care. So if you're in inpatient, exercise might not be appropriate during that acute withdrawal phase. But as you come out of that phase, it would be very important in terms of regaining some like endurance, as well as some endorphins in a healthy way. So it's very important. And diet is going to be important throughout this in terms of holistic treatment. So people that are in early recovery are commonly going to experience really high sugar cravings, especially if they've reduced their alcohol use. Alcohol tends to have a lot of sugar. So you're going to have people giving you some recommendations about not using so much sugar or what some other options are. So definitely important throughout. In that partial, you're going to continue to have medication management included. You're going to have both individual and group therapy. Those are things that are defined as part of this level of care. You're going to have education. Many programs will include 12-step meetings, although not all programs have 12-step or abstinence-based philosophies. That's something to note. And typically, there's going to be some amount of family involvement. So if you're in a partial hospitalization program, you're going to and from each day. Our program, for example, is from 9 a.m. till 3 p.m. Monday through Friday. So if you're going to and from home, it's likely we're going to try to include whoever you're going home to in some aspect of your treatment. If you're going to and from sober living, we're going to identify who your support system is to try to include that in your treatment. Step down from that is going to be called IOP is what you're going to hear, or PHP for partial. That is typically group therapy. It's anywhere from 9 to 19 hours a week in the state of Virginia. So that could be going to group 3 hours a day for 3 days a week, all the way up to that 19 hours if you were needing some additional services. That amount of time should be adjusted based on your treatment plan, based on what your individual needs are. Partial then is the 20 hours a week up through 30 something hours. So that's that line that you would cross where you're in the next level of care. And then you might step down to outpatient. Now, outpatient could look very, very different depending on what your treatment is. That could look like going to individual therapy once a week. It could look like going to individual therapy once a week and family counseling once a month. It could look like a med management check every month to make sure that what you're being treated with for your depression or anxiety is still effective or still needed. So there's lots of variety that could happen with outpatient, including some of these couple of things that are listed. So at our hospital in Hampton, we do offer inpatient detox. We don't offer residential treatment. So for patients who have that need, we do refer out into the community. We offer partial hospitalization program. Our program is brand new. It just opened in February of this year. I'm very excited. We offer IOP, which is also new, opened in September of last year. So we're coming on just past 6 months. And then outpatient is a step down. So for us, we do med management appointments, individual and family therapy, as well as an aftercare group for patients who've stepped down through this system. To determine the appropriate place or the appropriate level of care to step into, if you're not sure, does somebody need detox? Do they need residential? How do you know if somebody needs the difference between IOP and PHP? You would get an assessment by a provider, and they would use all that criteria we talked about in the beginning to figure out which level of care is the correct placement. And sometimes that placement needs to be adjusted based on symptoms. So if you step into IOP and are experiencing relapses or not able to maintain sobriety, it might be that somebody steps back up into a detox. Or when you step into PHP and do really well and don't need as much support, then you step down a level of care potential. I talked about a lot of things. I'm hoping I answered some questions. Are there any more questions that I can answer? Yes. Yeah, that's a great question. So I'm going to repeat it just to make sure everyone can hear it. And I'm going to paraphrase a little bit. But one of the things that's currently being discussed in the media, and specifically in Hampton Roads, this is something that's happening, is there is an ask or a call out there for certain situations to be responded to by medical professionals or mental health counselors as opposed to police. And so I think we've seen nationally some different situations where someone in a mental health crisis was responded to in a way by the police that there wasn't a successful outcome, or there was potentially a dangerous outcome. And so there's two ways that locally I'm aware of we're addressing that. So the first way is police officers locally have received over the last, I think, good amount of time, different crisis and mental health training. So there are people whose responsibility is to train police officers to recognize somebody in a mental health crisis and learn what might be an effective or appropriate way to respond to them. There's also, I think, relatively new, although I can't put a date on it for you, I wish I could, but I believe within the last year or two, response directly from the Community Service Board, a crisis counsel who works from the Community Service Board, with either EMTs or law enforcement personnel respond to a crisis that we know to be mental health emergency. And so our agency in particular doesn't do that, but the state agency, the Community Service Board, has people that are dedicated to this, and they can respond to those emergencies, potentially get people into a safer situation or a treatment situation as opposed to a continued legal situation. Not that. So I'm hoping that answers the question. Other questions? So for that in particular, I would say to follow up with the CSB would be a good resource for that, Hampton Services Board. I think there's been some publications on what those services look like and sort of how that's implemented in the community. But I do know that it's. I think the last thing I'll say, I think that there's been some opportunities with COVID for mental health to be stigmatized. So if there's a little bit of a silver lining there, I do think that there's been a little bit less stigma, a little bit more opportunity to recognize work. And I'm hopeful that without a pandemic, that will continue and help people get closer to the resources they need, help have there be less shame about access to treatment or resources. And if there's anything I can do to be a part of that, my contact information is up here. I do really appreciate the opportunity. Thank you, everybody.